any shooting paresthesia, you ask them, do you have any shooting pain down the head? They said no. You don't need to do this. You only do that if it's got a sharp shooting paresthesia. So we don't need to do all the tests. Only what the patient tells you, and think, okay, maybe neural involvement. Okay, do neural. But if it's just localized neck pain or maybe headache referred, no numbness, no ectopic fine, no shooting pain. Don't need to do this. Okay? Okay guys, so what we're going to go next is looking at the neck below level of C2. So below, so C3 to C7. Okay? Now in terms of coupling movement, it's easier than in the lumbar spine because every time you rotate in the neck, you get ipsilateral side bending. So as I rotate, you also get a little bit of side bending to the same side. So there's no contralateral rotation, so it's pretty basic. So as you rotate to the right, you get also a bit of right side bending. If you rotate to the left, you get a bit of left side bending. Okay? So flexion extension combined is between 10 to 13 degrees. Rotation around 2 degrees. And lateral flexion between 4 to 11. So it's really big variability. And again, guys, consider the age. As you get older, you're going to have less range naturally in the neck. So we're not going to be expected to get, almost 90 degrees rotation if you're like 60 years old or 70 years old. Yeah. So also think about the age. So the patient comes not with a headache, but more with a neck pain. I get the patient just to show me what movement hurts, and so show me how to rotate to the right or to the left, flexion, extension. It doesn't tell you which level, but just you want to see what's their movement pattern. Are they kind of compensating? Are they kind of dipping into that mid-cervical spine and rotating like this? And some people who have upper cervical stiffness, because half of your rotation in the neck happens from C1-2 levels. So it's 45 degrees. And then the rest of it is accumulative effect from the lower cervical levels between C2 and C7. So if you have complete restriction C1-2, how are you going to move? You will compensate with a mid-cervical spine. So people got that, kind of almost hinging in the neck. And when they hinge, what happens? They load the facets, they load the disc in the lower cervical spine and can cause a variety of issues as well over time. Now, if you look at this guy's extension versus the girl's extension, you can see they've got a different strategy. This guy goes cervical extension through the whole cervical spine, whereas the girl maintains lower cervical extension and really extends in the upper cervical spine. So you want to have a look how they move, what strategy they use, is that painful? Okay. And you can see that guys between 20 and 29 to 80 years of age, you've got natural decline of segmental movement, around maybe 1 to 2 degrees even per year. So naturally you're going to have less range as you get older. Unless maybe you're a gymnast, maybe you got, you're always doing a lot of yoga, maybe it's going to be outlier. But on average, you get a decline in range of motion over the years. So the first, remember we did already, we differentiated upper cervical flexion, upper cervical extension, if there's any symptoms. But then also you can look the same with lower cervical spine. So this, if you have a look at my neck, so if you do that, that will be upper cervical flexion. If I maintain this and I go down, that will be mid cervical flexion. And then further down, lower cervical flexion. Or if I go into upper cervical extension, maintain that, mid-cervical extension, lower cervical extension. So you can ask the patient, where are the symptoms? Is it, and which movements provoke the pain? So we can put a bit more stress on the system. And then, and today we're going to be introducing the movements called down slope or up slope. So they're a bit more osteopathic terms to identify the patient, where is the problem? Is it more in a down slope direction or up slope direction? So just remember about this. Up slope and down slope. It's just the beginning. It's just the beginning. I think you, after this holiday, you will need another holiday. After the 8 days of spinal course. I've got 6 days off. Do you think I'm looking forward to it? Just a little bit. Well, including travel time, I suppose, 6 days, so it's not much. But anyway, I'm looking forward to it as well. So I understand how you feel. I feel your pain. I'm in pain myself. But I had to hide, you know, I'm not going to show I'm in pain. Even with my back pain when I couldn't straighten up. Okay, so downslope problem. So now it will be clear. Just focus, I know it's a lot of information. Just try to kind of maybe pinch yourself a little bit or something. So if the patient's got pain on the right side, or limitation, with either side bending to the right, or rotation to the right, or extension, any of those movements, that will be considered downslope problem. So basically, facets are not going down, one in relation to the other. So maybe it's stuck. That's a hypothesis. So basically it's stuck, so it's not gliding down, so stiffness and pain, that's a downslope problem.
So it's the top facet not going down?
Yeah, one in relation to the other. One in relation to the other. So downslope problem. So if the pain is with either right rotation, or right side bending, or extension, that will be downslope problem. For the upslope problem, in this case, patient's got left side neck pain, as you can see that in the diagram. So the opposite movements will be limited and painful, opposite. So it could be opposite side bending, or opposite rotation, or flexion. So maybe facet superior is not gliding up in relation to one below, okay? So it's an upslope problem. So limitation in contralateral movements. Either flexion, right rotation, or right lateral flexion. Okay, and then if the patient's got two movement direction restriction, then we can do combined movements, the same thing what we did in a lumbar spine or upper cervical spine. Okay, but of course, if the patient's got only one movement direction pain and limitation, you don't need to do combined movements. Only if it's more than one direction of movement is painful and limited, then we can combine those movements together. Does it make sense? Okay. But don't worry about upslope and downslope. Tomorrow, still going to do this, and you will get it in terms of the techniques and that sort of thing. But I wanted to introduce tonight because it's not going to be as difficult tomorrow. Because if I start tomorrow, it's too much. So we start today. You have a good rest, and then we add things on. So, if you look at the biomechanics of the neck in the lower cervical spine, guys, yeah? And remember, the facet orientation below C2 is at 45-degree angle. So it's not horizontal like C0112, it's below, it's 45-degree angle, yeah, below C2. So in flexion, anterior structure gets compressed, posterior structures get stretched. In extension, posterior structures get compressed, and anterior structures get stretched. So again, we're looking at below C2, because below C2 you have discs, you get nerves, you have facet joints. So we want to know, is it compressive movement causing pain or stretching movement causing pain? Also, compressive movement is in line with downslope problem, and stretching or stretch pattern is more associated with upslope problem. Okay, so think like that as well, maybe that may help. And as we said, the coupling movement is ipsilateral. So you can see that as I rotate to the right, I get a bit of side bending to the same side, or as I side bend to the same side, I also get a bit of degree of rotation to the same side. So coupling is in the same direction. Okay. And you can see the rotation of the facet joints, guys, here is at 45-degree angle, so it's towards the eyes below C2. Okay. And this is sort of that diagram that you can see. You can visualize the intervertebral motion segment here, and you can say, okay, is it I'm compressing something here that causes the pain, or maybe I'm going away, I'm stretching something here that causes pain in the neck. So is the compressive pattern again, or stretch pattern? The same thing like in a lumbar spine, yeah? So the same thing. Compressive or stretch. Okay guys, so now we've got these two patients. So one has got pain in extension with right side bending, got pain on the right. This patient's got extension with right rotation, pain on the right. So is the compressive pattern or stretch? Compressive. It's a localized pain in the neck. So what most likely structure is irritated? That's it. Yeah, good. So please write down two movements that you assess in this patient if it's got high sin, and 4 movements if it's got low sin. Okay? Just list some of the movements that you would assess. Top one for high sin, the bottom one for low sin. Okay, so 2 movements that should reduce a patient's symptoms in this patient would be what, guys? Flexion and left side bending, or left side bending with flexion, isn't it? So going away from pain should reduce a patient with a high sin. For low sin, number 1 would be extension with right rotation, that would provoke the patient's symptoms. Number 2, extension would provoke the symptoms, but left rotation should make it a bit easier. So that's a hypothesis. And then switch those movements around. You can do right rotation with extension, again you expect the same pain, or right rotation would increase the pain, but flexion would make the symptoms better. Good. Okay, so we can told it correctly that it's a compressive pattern. Now you guys got second example here, pain on the right, and these movements are painful. So is this an upslope problem or downslope problem? Think again. So what about this one? Is it a downslope problem? Or upslope? Downslope, isn't it? And this one? Okay, because opposite movement, isn't it? So we're stretching something is a little bit painful. So that's more upslope problem. Okay, again guys, so this patient's got high sin, this one's low sin. Just list some of the movements that you expect that would be provocative or less provocative for this patient. So high again, yeah, and then low sin that one. Okay, so two movements that would reduce the facial symptoms would be what? Extension with right side bending or right side bending extension. So this should reduce, yeah, for axial problem. And number two, patient, so flexion with left rotation would increase the symptoms. Flexion with right rotation would reduce the symptoms. Then we switch those movements around, so we could do, then the third one would be, yeah, left rotation with flexion would throw off the symptoms. And number four, left rotation with roll, but extension should make it easier a little bit, huh? Good. So it's a more stretch pattern, isn't it? Or upslope problem for this patient. And at times you can have three movements, so we can combine three movements. So guys, so this one again would be an upslope problem or downslope problem?
Upslope.
Great. Yeah, it's an upslope problem. And this one?
Downslope.
Downslope problem. Very good. Okay guys, well done. So come around and we'll show you some of this.